So I am thrilled to be chairing this next session on tailored interventions and applied perspectives in harm reduction. And this is a fabulous panel, an interdisciplinary panel that's going to be providing some work from a range of perspectives. We're going to be hearing about some empirical work, empirical research that some of our panelists have undertaken, advocacy initiatives, and frontline perspectives. So I want to leave us lots of time for questions at the end. So I'm just going to get us get this panel started, and we begin with Janet Butler-McPhee, who is the Director of Communications and Advocacy from the HIV Legal Network. And she's going to be speaking about the Good Samaritan Drug Overdose Act. Welcome, Janet.
Thank you so much. Hopefully my screen is working properly and everything's good to go. So I'm here in near outside Halifax, also the territory of the Mi'kmaq. So just wanted to acknowledge that up front. And I'm going to be speaking about the Good Samaritan Drug Overdose Act and its real world impact. I will start this by saying I'm not a lawyer. I work with a bunch of really smart lawyers, but I'm actually the Director of Communications and Advocacy. This is not advancing. There we go. So the Good Samaritan Law, for those who are unaware, was created in 2017. And it was introduced in 2017, and it was done in response to the growing opioid overdose crisis and meant to provide protection against criminal charges related to simple drug possession. And this was for when people were calling 911 at the scene of an overdose. It was meant to basically combat a really important problem. One Ontario study found that only in 46% of cases was emergency response ever called in the case of overdoses. So the law itself is imperfect, but is meant to prompt people to remove barriers, to having people call 911 and ultimately to save lives in the case of an opioid overdose. The law provides protection against charges for possessing drugs for your own use, so personal, simple possession, and violating conditions of parole, bail, probation, or conditional sentence in the instance of simple drug possession charges. It does have limitations, though. It's not blanket amnesty, and so it doesn't provide protection against, from selling illegal drugs or trafficking, and then that brings in the question of quantities. It doesn't provide protection against offenses other than simple drug possession. Any outstanding arrest warrants does not cover that, and violating the conditions I mentioned before for an offense that is not simple possession. So it's pretty obvious why this could be seen as limiting in terms of the effectiveness of the law itself. So to try to make things a little more clear, the HIV Legal Network, where I work, formerly the Canadian HIV/AIDS Legal Network, we produced a bunch of wallet cards, and they were laminated and distributed across Ontario. And they did tell people what the law does and does not protect against. So the study that I'm going to refer to today was funded by the Law Foundation of Ontario. It's a research only and was no advocacy and was Ontario sites only because it is the Law Foundation of Ontario. The study duration was from April 1st, 2019 through March 31st, 2020, with a few COVID-related delays in reporting, and I can imagine other people have experienced that as well. And the lead organizations were the Canadian HIV/AIDS Legal Network, now the HIV Legal Network, and Ryerson University with Dr. Emily van der Meulen. So the study design was 2 semi-structured focus groups in 3 locations and 5-minute confidential surveys in 5 locations. And they were across Ontario, so Toronto, Ottawa, Sudbury, we had both focus groups and surveys, and in Hamilton and London, we had surveys only. And we had on-the-ground research study partners who helped us find participants, who would help us find the participants who would have some connection to the law, the Good Samaritan Law and hopefully be willing to participate in either focus groups or in the surveys. So the research questions, the most important thing about this was what we wanted to find out. And that was, first, we needed to know what people knew about the Good Samaritan Law and how they came to know it. So that was the first and one of the most important pieces of this. We wanted to know also what people's lived experience was of the Good Samaritan Law. So it was meant to help people to call 911, feel that they were able to call 911 in instances of overdose. We wanted to know how this was really playing out in real life. And so we wanted to evaluate existing public legal education materials, which is a unique feature of this study. So basically communications products that try to translate legalese for facets of the public is what I'm referring to. And we wanted to evaluate the Good Samaritan Law from the perspective of the people it's meant to help. So those would be people who use drugs or people who might find themselves at the scene of an overdose for whatever reason. So we had 6 focus groups, 2 each in Ottawa, Sudbury, and Toronto, and 40 focus group participants. So we met our quotas for that. We had 69 survey respondents. And you can see here the gender and ethnicity breakdown as people self-identified for both the focus group and the surveys. I want to talk a bit about the research experience. This was my first research experience as a principal investigator. And I want to say first that it was very collaborative. So we had input from people who use drugs from the very outset. We really centered lived experience, and I think it's really important to note that all participants were compensated for their time and expertise. It was very data rich. So we had generous contributions, lots of enthusiasm, and we had way more data than we originally had within the scope of the research project. And it was really eye-opening. And oftentimes people had very specific feedback and suggested remedies for what was and wasn't working with the Good Samaritan Drug Overdose Act. Once the final survey was administered and all the focus groups were transcribed verbatim, we, the researchers, began to the collaborative analysis process. And what this means was it was a line-by-line reading of transcripts to create a list of thematic topics and a detailed code book. So we released a preliminary findings report, and we released this just in June of this year. So you can see we're still going through the data, but I want to talk through some high-level findings from that report. So first, finding number 1 was that the Good Samaritan Law has helped to humanize those who are directly affected by the opioid overdose crisis and who are often othered by society. So the focus group respondents really felt that this law caused more people to recognize the scope of the crisis by putting a human face to it. Some focus group participants, it's important to note, were actually advocates who pushed for the law in the first place. And really their contribution to this can't be understated. And it really, the Good Samaritan Law, respondents felt that people outside the immediate community, so people who wouldn't necessarily identify as people who use drugs, it made it so that they were feeling like these other people were willing to take action now on their behalf, willing to call 911, understanding a bit more about what an overdose might look like. They would say it's not universal though, and there's still a lot of stigma related to this. And so I think what's important to note here is, yeah, not universal, but certainly there was a positive impact that the law really helped with in terms of letting people know what was happening with the opioid overdose crisis. Finding number 2 was that the knowledge and interpretation of the Good Samaritan Law vary greatly. And what I mean by this, all participants had some knowledge of the Good Samaritan Law. It was in our screener. And many of them actually had a good degree of confidence, but a lot of people couldn't point to specific protections or limitations of the law. There was a lot of people who thought it was the blanket amnesty and would protect them against anything if they called 911 at the scene of an overdose. A lot of people took this opportunity during the focus group to ask some unanswered questions. A lot of participants feared that their peers did not know what the law was, and they also feared that first responders, and especially police, did not either know or understand the law. So finding number 3, the Good Samaritan Law looks different on paper than it does in practice, and experience with enforcement is an ongoing issue. So perhaps very unsurprising. But we looked at experiences with focus group participants, their experiences with dispatch, with ambulance, EMT, fire, and of course, police. So a couple of things to note about this. Often police are called to the scene of overdoses, whether they are requested or not. Most participants found that they were unwilling to reverse overdoses and ceded that control to EMT counterparts. Almost a universally negative reaction to having police there. And there was a varied response to other first responders, so ambulance, EMT, fire. But there was still a lot of stigma for people who were responding to an overdose. And the role of stigma is probably also unsurprising to people, but in Good Sam enforcement, focus groups unearthed that stigma existed related to gender, race, particularly indigeneity. We had a lot of Indigenous participants in these focus groups, whether someone was HIV and or hepatitis C positive, whether someone was a sex worker and or perceived to be a sex worker, the stigma around drug use itself, and homelessness. So a lot of things at play when it came to what the law looked like on paper versus how it was enforced in real life. And then the last piece that we wanted to look at was around the public legal education materials. So again, perhaps unsurprisingly, with the confusion around the law, given its protections and limitations, and the fact that it is not a blanket amnesty against criminal charges, when someone calls 911 in the case of an overdose, there was a lot of confusion that led to perhaps the communications around it being confusing as well. So I think a basic mistrust of law and particularly police made communicating it complicated, although a lot of people had seen a lot of the products, the communications products, public legal education products that had been put out by various community groups. And you can see that for the most part, public legal education is still important, and that people are learning about the Good Samaritan Law through harm reduction workers, through word of mouth and their peers, and via some of these educational materials produced by government and community groups. So I think the key around this is really looking at making them created hand in hand with providers and within community, and that they need to be rolled out with people on the front lines, and including people with lived experience, in order for them to be widely distributed and picked up. And we'll be incorporating this feedback as we move forward in our public legal education and communication products at the HIV Legal Network. Another interesting thing was around the factors into the decision to call 911. Now, I'm not going to read all of these out, but I think what's important to note about these is that some of them can be or could potentially be addressed by law, but a lot of them have to do with enforcement, and a lot of them have to do really with treating drug policy and the use of drugs as a criminal issue here in Canada, as we know it is. So survey findings, when we asked people what they thought ultimately should change around the Good Samaritan Law or how it is enforced, you can see that people really had a lot of strong feelings about police and the enforcement, about what police needed to know about the law, and also about the law's protections themselves. There was a lot of different ideas, and again, this speaks to the really data-rich experience we had with this study. Which leads me to finally what comes next. So like I said, we just have finished the preliminary part of the study findings, but some key themes really came out of the process. And first and foremost, the idea of no police at overdose scenes. So we're looking, for example, right now it's sorting through dispatch protocols and how police come to be at overdose scenes. looking at advocating for decriminalization of simple possession and beyond, as opposed to tinkering with the Good Sam law itself. There's a lot of things that might be addressed via tinkering through that law, but really it's this overarching framework of criminalization that is confusing and engenders the mistrust of how the law is actually being carried out. Then looking at a uniform understanding of and training on the Good Samaritan law. So the idea that emergency responders and actors, and also people who use drugs themselves and or may witness an overdose, really on getting out there what the Good Sam law is and what people need to know who are actors in potentially in an overdose situation. And also partnering to scale up public legal education materials and to remove, I guess, demystify as much as we can around that and around the law itself. So you can see, I'll leave you with, this is one public legal education piece that we've just put out at the Legal Network with some partners. And it's around communicating the law and problems with the law in this time in comic form, so that people can really understand its intent and understand what would need to change in order for it to function as intended. And ultimately people to call 911 when an overdose happens and save lives. So I want to thank you for your time. And if you have any questions about any of the products that I've spoken about, you can go to our website at hivlegalnetwork.ca, and they're all available in both French and English. Thank you.
Thank you, Janet. What a rich data set. That was just a fascinating presentation about the Good Samaritan Drug Overdose Act. I'm now going to turn to Sandra Ka Hon Chu, who is the Director of Research and Advocacy, also from the HIV Legal Network. We're very lucky to have both Janet and Sandra with us today. And Sandra's going to be speaking to us about prison needle exchange programs at the federal level and talking about some of the advocacy around that. So I'm going to turn it over now to Sandra.
Thank you, Vanessa, and thanks for the introduction. I'm just going to share my screen now, so bear with me. Okay, so I'm going to talk about the Correctional Service of Canada's Prison Needle Exchange Program. This has been something that we've been working and advocating for more than 2 decades, and there have been a number of developments in the last year that I want to share with you today. So just to begin, I wanted to share about who is actually in prison, and in Canada, there's 2 prison systems. There's a federal system that's responsible for adults serving 2+ years, and then there's a provincial and territorial systems. I'm going to be focusing on the federal system, which is Correctional Service Canada. And as we know, Black people and Indigenous people are majorly, grossly overrepresented in the prison system. And you can see some of the statistics here. There's no sign of this slowing down. In fact, it's accelerating. And so any denial of healthcare to these to people in prison means they'll disproportionately impact Black and Indigenous people, and in particular, Indigenous women. Drug use in prison is quite common. We know that at least 30% of women and 14% of men in the federal system are incarcerated for drug-related charges. We know that many people, 80% of men, have a substance use issue when they're entering federal prison. I think the stat I have for Indigenous women is more than 90%. It's very high. And people don't stop using drugs when they're inside, when they're behind bars. The latest statistics we have are from the Correctional Service of Canada. This is a decade-old survey, but from what they shared at the time, when people were self-disclosing their own injection drug use, 14% of women and 17% of men said that they injected drugs within the last 6 months in prison, and about half of them share their injection equipment. And this is really problematic because there's no access to sterile injection equipment in the vast majority of prisons in Canada, federal and provincial territorial. So what we've heard from our partners at PASAN, which is a prison outreach group that does work with people living with or at risk of HIV or hepatitis C, is that the most common injection equipment is this G2 pilot pen. That's what people fashion into their injection equipment. They use it if they can access it and turn it into their equipment to inject. I've also heard from people when I've interviewed people who are incarcerated about using diabetic needles that they might take from the healthcare unit without people's knowledge, or, anything that they can fashion, they do, but this is the most common device. And for many, many years in Canada, we didn't have access to a needle and syringe program. These exist around the world. They've been in Switzerland for more than 3 decades, and multiple other countries. And there have been a lot of evaluations done of these programs, and they've been proven very effective. And so here is just a mapping of some of the benefits of these programs. They reduce needle sharing, overdoses, because people aren't rushed to inject, or they don't need to borrow equipment or rent equipment from other people, fewer abscesses, fewer needle stick incidences by guards during cell searches. So when you have a regulated program, people aren't hiding equipment in their cot or behind any of their belongings, and guards are less likely to get stuck with a needle accidentally. And there's a lower risk of HIV and hepatitis C transmission. They've been functioning successfully without any security incidents, not a single case of anybody being attacked by a needle from such a program in the 3 decades they've been operating. And why is this so important? Because people are reusing equipment behind bars. And then you see, as a result, one of the main drivers then is the shared use of injection equipment means that there's much higher HIV and hepatitis C prevalence amongst federal prisoners. And the latest statistics I have from a 2016 study is very high. You can see the numbers on your screen. So prison needle exchange syringe programs are not a radical idea. Needle and syringe programs in the community have been around for decades, as we know, but they've also, the ones in prison have been approved, endorsed and supported by multiple organizations. Too many to list here, but here's just a quick overview, some of them dating back to the 90s, from CSC's own expert committee on AIDS in prison. CSC, the Correctional Service, had a study group on needle exchange in prison in 1999, and they also recommended them. We've got them from the Ontario Human Rights Commission. So you can see multiple actors, including the Correctional Investigator of Canada, UN agencies, have said these are great programs that have positive health benefits without compromising security. And so what we sought to do a few years ago, again with Emily Vandermeulen, who was the previous co-researcher on the Good Samaritan Project, was look at what model might work in Canada. And again, we wanted to hear directly from people who are in prison, formerly incarcerated, and people who work with them, like the many outreach workers that do work in prison. What model would work best in Canada, given that there's a few main models that exist around the world? So there's 4 main models. The first one is a dispensing machine model. And so you can see here's a picture of one in Switzerland. What people have shared was it's great because it's the most anonymous model. The model that preserves confidentiality the most. You can, as long as you keep that machine somewhere that's out of view of security. But the problem is there's no face-to-face contact if there's a downside to it, and it's also reliant on healthcare to maintain. And we know from experience with bleach, which is another harm reduction supply that's provided in prison, that often bleach dispensers, for example, go empty and people don't have access for weeks on end. So this is one model. Another model is peer distribution, and the only place in the world that it exists is Moldova. And here, they actually started out with a healthcare distribution model, but found that no one was accessing it, and they moved to peer distribution, meaning other people in prison were getting the full bulk of supplies and then redistributing it to their peers. And they found that this led to major uptake. A lot more people were using the program because of confidentiality. And if there's a downside, people were talking about sometimes the peer workers talk too much, or maybe there would be some power dynamics that were associated with that. When somebody has all the supplies and power in their hand, this could be problematic. So it's really important to train and find the right peer. The third model is community worker distribution, meaning an organization like PASAN, which I mentioned earlier, or any other external NGO, civil society organization that might be already doing needle distribution in the community, goes into the prison and does a distribution. And people really appreciate this approach because there's a relationship of trust that has been developed with the community-based organization. The problem is that the access is obviously limited. People aren't in there, likely not in there every day, especially in a security lockdown. And we know with COVID, many of the organizations that I am in touch with who do prison work have had their visits suspended. So in a model like this, you wouldn't have, it would be sort of really vulnerable to security lockdowns and others, a global pandemic, for instance. The final model of distribution is healthcare staff. So mostly in the models with which I'm familiar, it's the nurses who do the primary distribution. So you have to disclose your use to a nurse, and then they will assess you, and then they will provide you with the equipment. But the downside of that is people expressed to us in the study was it's hard to build a relationship with somebody that still works for the institution. So it's really contingent on whether or not you have a relationship with a healthcare staff that you think is a good one, and also you don't think that they're going to share that information with other staff, including security staff, which is a major concern. So we came up with these recommendations based on that study. Among them, the need for easy confidential access. There should also be a multi-model approach to distribution, so not just one model, because there's pros and cons of the different models. Many people shared with us that they wanted a hybrid model or a multi-model, and that prisoners should have an active role in determining the program structure, et cetera. So if you want to take a look at the full report, it's available on our website, but these are the 6 sort of main high-level recommendations that emerged. And as a companion piece to that, we also, and in the face of a government at the time, this was 8 years ago, that was very hostile to harm reduction, refused to implement a needle and syringe program in prison despite, at that time, more than 10 years of advocacy. We launched a constitutional challenge. We, meaning the HIV Legal Network, along with PASAN, Katie, the Canadian Aboriginal AIDS Network, and Steve Simons. He's a man at the center of this case. He was incarcerated at Warkworth Federal Prison in Ontario. He was infected with hepatitis C when someone took his equipment without his knowledge. And he was somebody who got regularly tested inside. So he knew his status. He was getting tested, and he went in negative for hepatitis C. And about shortly after he was in segregation, someone used his equipment, he tested positive. And when he confronted the man said, "I'm hepatitis C positive, and in fact, I used your equipment." So the clear, you can trace it back to it's very much happened in prison. And here are Steve's words. He shared with us why he wanted to be involved. There's a lot of repercussions for people in prison, as I think people are aware. There's bullying that happens. If he's launching a case, he could be penalized for it. But he shared with us, he was really passionate about this case. He wanted to prevent the spread of hepatitis C and HIV and protect other people's health. And you can see in the quote here, so many people would be sharing equipment. When I speak to people inside, I've heard stories of people sharing between 40 and 50 people, one makeshift needle, maybe made from one of those pens that we talked about earlier. And it's blunt by the time it's passed to you, but people have no other option. So they're sharing. And this is why Steve wanted to be involved. And so we centered the case on 3 main areas of law: the Corrections and Conditional Release Act, and specifically the 2 provisions that say that people in prison have the rights of all members of society. They retain the rights of all members of society, including the right to health, and that also the service shall provide every inmate with essential health care. And we described in our case needle and syringe programs access to sterile injection equipment as a form of essential health care. We also based it on international law principles. The fact that the principle of equivalence in healthcare is reflected in the Nelson Mandela rules, which is guiding principles for prisoners' rights, and includes a whole section on healthcare services, Rule 24, so that prisoners should enjoy the same standards of healthcare that are available in the community. And this is really key because we know that needle and syringe programs have been available and existed in communities outside of prison for many, many years. And by the time we launched this case, it had been more than 2 decades. Yet people who arguably need it most, many people who are in prison have substance use issues or maybe incarcerated for a drug offense. They might be using a needle and syringe program in the community, but as soon as they're in prison, they don't have that access. And the third argument, and the main part of our argument, was the charter. So we argued Section 7 and Section 15 of the charter. Section 7 being the life, liberty, and security of the person provision, and equality provision of the charter. So 6 years into the case, it went through a lot of twists and turns, and it was quite a lengthy case. But 6 years into the case, and before we actually had a hearing, CSC announced in 2018 that they're going to introduce a needle and syringe program. Here is the text of the announcement, that they're going to do it to protect the health and safety of all Canadians, including federal inmates, and that they're going to do it in 2 prisons starting in June 2018. So the two prisons that they introduced it in about 2 years ago now was, the first was in Ontario, Grand Valley Women's Institution in Kitchener, and then a men's federal institution in Atlantic Institution in New Brunswick. So as soon as they announced that the PNEP, the Prison Needle Exchange Program, there was an uproar from correctional officers. You can see this is just like a screenshot of some of the media reporting at the time that I think the correctional officers' main response was that it was not their job, that was endorsing drug use, that it would make their lives more dangerous because of the presence of because of the presence of injection equipment, that there would lead to attacks. And here's some of the information from CSC itself about the type of model that they adopted. They adopted something called a threat risk assessment model, and that's something they use for other people who use who need access to EpiPens or people with diabetes. And basically what happens is a person will go to healthcare services, fill out a form and ask to be part of the program, disclosing their own personal use. The nurse will either reject or accept their application. And then it goes over to the security staff. And the security staff will then assess the application and then ultimately to the warden. So there's 3 levels of gatekeepers, and the security staff or the warden can ultimately veto your participation based on what they say are security threats. If you actually make it to the program, so you disclose your use and then there's no guarantee of participation, but once you make it to the program, then you have to store your kit in an approved area and show it twice a day at a stand to count. And if there's any drugs visible in the kit, the equipment will be seized and you could potentially be penalized. So we continued with the challenge because we felt that the model was unconstitutional. It didn't meet the standards that have been set out in other models elsewhere. It was gonna really minimize access or limit access. And 8 years after we launched, we got a decision from the Ontario Superior Court, which was very disappointing. The court acknowledged that there were compelling constitutional arguments supporting access to this measure as essential healthcare. And they also recognized that the case raised important issues. But at the end of the day, the judge in this case found that it was premature because the program was still being rolled out. It was only partially complete, and it was continuing to evolve in response to some concerns raised. So he declined to find a constitutional violation, and he found the case premature. So right now, the PNEP is still only in 11 of 43 federal institutions. The first 2 I mentioned and the rest that are on the screen. The rollout has been delayed. In response to COVID, it was suspended in March, and we know that no other programs have been implemented in any other federal institution. There has been no independent evaluation of the program done so far. There's this a researcher that's been retained by the CSC to do an evaluation, but there's no commitment to share the findings of her research or for CSC to share it with any of the stakeholders or make it public. And we're concerned now that with having lost the case that the PNEP could be canceled or implementation could be further delayed. So it's very disappointing, and we continue our advocacy outside of the courtroom with engagement with the Federal Minister of Public Safety, to the extent we can, the Minister of Health, and ongoing engagement with other policy advisors in those departments, because we think the program is still deficient and we need to improve it. And more importantly, we need to enshrine it in law. So that's it. I know I raced through a lot of slides, but if we have any questions, I'm happy to answer them at the end. Thank you.
Thank you, Sandra. That was a super interesting talk, and I'm sure there will be lots of questions. I have some questions for the Q&A on those prison needle exchange programs and the current status. So our next speaker is Tali Cahill, who is the nursing team lead of the Oasis program at the Sandy Hill Community Health Center. And she'll be providing a frontline perspective on the future of harm reduction. Over to you, Tali.
Okay, thanks, Vanessa. I'm just going to try to share my screen here and hope that it actually works. Give me a second. Okay, everybody, I hope can see that. So again, yeah, my name is Tali. I'm the nursing team lead of the Supervised Consumption Center and the primary care clinic we have at the Sandy Hill Community Health Center. And I'm here trying to give a frontline perspective on the future of harm reduction, but I have to say that I am a frontline harm a healthcare worker. But of course, the real frontline people, when you're talking about harm reduction, are people who use drugs, who respond to the majority of overdoses and are taking care of their own communities and have been saving each other for a long time before the healthcare system got involved. So I did want to get that out there. This is a little bit different from your other presentations you're going to see, because you're kind of seeing my brain and a little bit about what's happened in the last year, and so what's going to happen in the future. When they asked me to do this talk earlier in the year, COVID hadn't happened. I'm not sure what I was going to talk about, but now so much has gone on, and I'm really wondering what's going to happen next. So I'm just going to walk you through a little bit of what my thought process is in terms of the past and what's going to happen in the future. So this is kind of my really bare bones timeline. I didn't put all the months in. I'm sure I've left something out. I'm sure I got the order of things, but this is kind of the year to me in things that have affected my clients, things that have to do with kind of the world of harm reduction. And this is really what we've been living through the past year, which is not just COVID. I know people are going to talk later tomorrow just about COVID, but it's so much more than that. And it started really for me when the Alberta government released their supervised consumption site report, which is an interesting document, basically kind of a criticism of supervised consumption, of harm reduction in general, and really set the tone for me for the year, because of so many erroneous things that were suggested. And it really showed me how little the regular public knows about the services we provide. I think that report was released in February or March, right before Ontario shut down, which really changed everything for our clients and our services. After a little bit of time being shut down, people realized that what was happening for people who use drugs was not tenable at all. Out in BC, they started a pandemic prescribing protocol, prescribing safer supply of not only opioids, but also stimulants and benzos and things, realizing that people were putting themselves at risk going out trying to buy drugs, and that we could do that in a safer way while people were picking up drugs from the pharmacy. A little bit after that, in Ontario, some of the addiction med physicians started to talk themselves about how to relax the guidelines around methadone and Suboxone prescribing, so that people didn't have to come to the clinic all the time. People wouldn't have to go to the pharmacy every day. People wouldn't have to do urine drug screens. And that was a conversation that was long overdue. And COVID really pushed that out to the forefront. In May, of course, George Floyd was killed by police, and he wasn't only a Black man, but he was also a person who used drugs. And I think that it was really interesting to see, for me, a lot of the protest around after his death, because there was a lot of shaming and stigma around his substance use, but also people really recognized that he had a right to live, and that his death was not legitimized by his substance use. And I really was so happy to see in the protest those kind of conversations happening about the proper response to mental health issues, to substance use issues, and they're really heartening to see. And during the summer, the federal government started funding some of their safer supply pilots. Might have been a little bit before that. The ones in Ottawa started during the summer, and those are programs funded by the federal government in order to provide a regulated, prescribed supply of opiates to people who use drugs. Shortly after that, out in BC, there was a class action suit filed by people who use drugs about the switch from methadone to methadose, and how that switch was part of why the opioid epidemic has been so devastating out in BC, just because methadone, the drugs that people, their treatment that they had become used to, had changed without their knowledge, without their permission, and how it really affected them, even as pharmaceutical companies and the government said that it wasn't an issue. So that that lawsuit was filed in the summer. And then in August, the supervised consumption site in Lethbridge, Alberta was closed, and that was the busiest supervised consumption site in North America. A really pretty amazing place where people could not only inject and snort drugs, but also smoke them. And I had visited a year ago, I think, and was really impressed by what they did for the community and the services they provide. And now really there's very few services for people in Lethbridge as a result of that. Then, the American election happened, and I just put this in there because, it started to be, everyone was talking about everything in terms of harm reduction. So voting for Joe Biden is harm reduction, voting in general is harm reduction, and a real watering down of the term and the work that people who use drugs have done to take care of themselves and their health. But shortly after, during all of this, I don't know if everyone noticed this election brouhaha. It was interesting to see not only the amount of states that legalized cannabis, but the fact that Oregon decriminalized small amounts of heroin and cocaine, which is really kind of amazing for North America, and amazing considering the real ideological, left-right divide in the US. And still people are starting to realize that the war on drugs is really a failure and killing people. And then a couple of days ago, Ontario's overdose numbers were released, and I'm going to go to those next. And this was tragic for me to see, and not surprising for anyone who works in frontline harm reduction. I don't know if people have seen them, but so 34 people were dying a week, which is horrendous before the pandemic, and that increased to 46 people per week in the first 3.5 months of the pandemic, with an expectation by the end of the year that 2,271 Ontarians will die of overdose, of poisoning, really, by the end of the year. This, again, is not surprising to anyone who's lived through this year and lived through the spikes in overdoses and lived through the really unpredictable drug supply out there, but seeing the numbers is really quite shocking. And I don't know anyone who hasn't lost someone close to them. And we learned a little bit more about in this Public Health Ontario report about how there've been, not surprisingly, more deaths in racialized neighborhoods, more deaths in places, neighborhoods with material deprivation. If you see the amount of homelessness that is out on the street, the amount of despair, none of that is surprising to you. And we also know that more and more stimulants were involved in these deaths. So calling it an opioid crisis, I sometimes make that mistake. I call it that. It's not really about that. It's a drug poisoning crisis. And we see that every day in the amount of crazy drugs that are in people's drugs, the caffeine, the benzos, the horse tranquilizers. People really have no idea what they're getting, and it changes day by day, and that's killing people. So when I think of the future, I'm thinking to myself of maybe this past year has proved to people that harm reduction is an essential service, not only because we keep people alive, but we offer hygiene for people, food, access to health information, a sterile place to be, to wash your hands, to exist. And that is something that people who use drugs and homeless people do not have. And it is really important for keeping them healthy. It's amazing. In Ottawa, we've had very few COVID-19 deaths in our population of people who use drugs and homeless people. I think it's partially, the work of all of our 4 excellent supervised consumption sites in really distributing masks, making sure people have a place to wash up, because we know that hygiene is really important. Unfortunately, these services are not spread equitably across Canada at all. The supervised consumption site in Saskatoon is basically supporting itself through t-shirt sales, and they are great t-shirts, but that's crazy that an essential health service is having to sell t-shirts in order to exist. And really, with that supervised consumption report out of Alberta, we're seeing this politicization. As much as harm reduction, we realize how many lives we're saving. It still seems to be that although the federal government is supportive, we're not supported necessarily equitably across the provinces and different municipalities. And much as we are an essential service, that we are also experiencing the same burnout that all healthcare sectors are feeling. And that is something that I think about in the future of harm reduction, is we really have to take care of our people and our staff. And that's really, really important, or else we're going to lose a lot more people. One other thing that I'm thinking about the future is really safer supply and treatment. And I put those on the same page because they're not exclusive of each other. So the safer supply pilots that we're doing right now, we should have some evidence back. We should have some information back from clients and some empirical information about how those are working, and those should inform what we're doing in the next year. You know, what we've noticed here in Ottawa, and I think there's been some reports in BC, is that there are limitations to these programs. They are, you know, they're for people with diagnosed opioid use disorder. They're getting pills to inject, and really, you know, people should have the option to inject drugs that are like the drugs that they are buying on the street in order to stay safe. And not giving them that is only protecting a smaller segment of the population. And you're really not protecting people who are new users, or people for whom Dilaudid doesn't work really. And hoping that with the new prescribing guidelines that we've been trying out during COVID, that we can realize as a society that if we are going to save people, we are going to need to relax our prescribing guidelines and lower the barriers. Again, I talked about Oregon and the failure of the drug board policies. I'm hoping in the future we're just going to talk about decriminalization, drugs, people, really looking at the carceral systems that we're funneling people through and how they cause trauma and they cause people to use more, and really stepping back from those kind of failed policies and things that don't work, and really destabilize so many people who are trying to get help. You know, I was doing research for this report, for this slideshow, and last night I read this great article by the International Network of People Who Use Drugs, and not surprisingly, people who use drugs are saying this way better than I'm saying it, and I really recommend that you read it. It's called COVID-19: Enacting a New Normal for People Who Use Drugs. And although I have to say, today is not a great day for me because we've lost someone really close to us at Sandy Hill. I do have hope for the future that in this time of COVID and everything changing, what I've really seen is all this accepted wisdom is really up in the air. We have managed to do crazy things and amazing things and change our society. And so if we could use that to change the way that we treat people who use drugs, if we could change, you know, all those things that we said that we just couldn't do, like legalization, like making treatment easier, like decriminalization of homelessness, housing people, I think we might be able to do that now. You know, if we really listen to the perspectives of people who use drugs and public health experts, and amazingly, they all agree about what needs to be done. I really do have hope for the future. And to me, when I think of the future of harm reduction, it's really about focusing on reducing structural harm to people. So we've done a great job of really of reducing infection and of saving lives and really getting down deep with those things. But we need to focus on the harms that we do to people who use drugs, the iatrogenic harms that prohibition has done. And those are the things that really are going to carry us. We can't, supervised consumption is great, and I run a site and I love it, but it's really, we're waiting to the last 30 seconds of someone's life to save them. And we need to do a better job of saving them earlier before it gets to that point. Anyway, and that's what I've got for you today. Thanks.
Thank you very much, Tali. Very interesting to think about what the future of harm reduction looks like. And I know the number of the themes that you touched on towards the end of your presentation: safer supply, low barrier treatment, decriminalization. Some of those we're going to be addressing in the next panel. So, and we'll certainly talk about them in the Q&A period as well. So thank you very much. Our last speaker on this panel is Professor Elaine Hyshka. And she's a professor of public health, health policy and management at the University of Alberta. And she's going to be speaking about implementing supervised consumption services in acute care. Elaine, over to you.
Great, thanks so much. I'm just gonna load my presentation. All right. So before I get started, I just wanted to acknowledge that I'm coming to you from Edmonton, and I work at the University of Alberta, and the University of Alberta is situated on Treaty 6 territory, which is traditional lands of First Nations and Métis people. And I just wanted to say that it's very nice to be able to present on this panel with such great speakers, and I think there is like a continuous thread that kind of runs through some of our discussions, and I think that relates to just like how harmful the criminal law is to people who use drugs, and how important it is to change that law as a way to improve health and safety. So today I'm going to be talking about some research that we conducted at the Royal Alexandra Hospital, where I'm the scientific director of the Intercity Health and Wellness Program. And my research team works very closely with the Addiction Recovery and Community Health team, which is embedded addiction medicine consultation service that cares for people who use drugs when they end up at the hospital. And we recently, the hospital recently enacted a supervised consumption service for patients. And so today we're going to talk about some of the findings from our qualitative process evaluation of that new service. So everyone knows across the country that opioid-related hospitalizations are increasing. And we know that when people who use opioids or people who use other substances are admitted to hospital, a significant proportion of people will continue to inject while they're hospitalized or use drugs while they're hospitalized. And traditionally, hospitals have addressed substance use within their walls by having either formal or informal zero tolerance policies, or turning a blind eye to substance use. And this is problematic because it creates a whole host of risks for people who are using drugs within hospital environments. And although supervised consumption services are increasingly implemented in Canada, and we have 38 federally sanctioned ones and many more overdose prevention sites, no research has examined hospital-based supervised consumption services that are designed to reduce risks for patients who are getting acute care. So the Royal Alexandra Hospital Supervised Consumption Service is North America's first SCS for acute care inpatients. When it first opened, it was for inpatients, and now it does serve patients who are waiting to be seen in emergency as well. It was designed to improve patient and staff safety. It provides sterile consumption equipment, either for use in the site or to take away, as well as safe disposal of harm reduction supplies and medical treatment for unintentional overdose. The vast majority of those who access the service are already connected to the addiction recovery and community health team, and often referred by them. And the rollout was accompanied by a large staff education campaign in support of health authority level policy. And so I have data from the first 2 years of SCS provision. So June 1st, 2018, it opened April 30th of 2018. So from June 1st to May 31st of 2020, there were 5,789 supervised consumption service visits, but that's actually a fraction of the number of patients that have been in the service. And I'm not going to talk about it today, but the SCS also includes an embedded injectable opioid agonist treatment program. And so patients, there's many more thousands of visits that have accommodated patients that are accessing that treatment. And so far, the SCS for supervised consumption and for injecting illegal drugs has served 242 unique patients, reversed 41 overdoses, and there's been 0 deaths at the site. At the hospital, the majority of drugs that are injected are opioids, so either Dilaudid or morphine, or heroin or fentanyl, and about 13% of injection episodes are for stimulants, and the majority of that is methamphetamine. So our objectives with the research I'm presenting were to examine patient and staff perspectives on the implementation of the SCS and how it operates and what the impacts have been for people. and to develop clinical guidance for delivering SCS in acute care settings. The hospital regularly gets asked by other jurisdictions how they did it and what's worked and what hasn't. And so the study was really the first step in evaluating the service, and it's designed to produce new insights on this very novel service model, and also to use the research to improve the service further. So we conducted a focused ethnographic study with patients and hospital staff, and this included 28 qualitative interviews with patients who had been offered access to the SCS, and 20 semi-structured interviews with staff who care for people who use drugs, either in the hospital, either in the SCS or in other parts of the hospital. And of course, we got ethics approval from the University of Alberta. And our study was designed in collaboration with our community advisory group, which includes 15 people with lived experience of substance use, homelessness and poverty, and the majority of our membership in that group identify as Indigenous. So I'm just going to give a preliminary kind of overview of some of the data. There's a lot to go through, and we only have like 10 or 12 minutes. So I'll start by discussing some of the barriers and facilitators identified by patients to actually using the site. And so our participants, out of the 28 patients we spoke with, 20 had actually accessed the SCS, and the other 8 had declined to access it. So we got a good range of views. The mean age was 36 years old. 54% of our participants were male, 57% identified as Indigenous. And for the participants in our sample, the average length of drug use had been 18 years, and the range was 2 to 30 years. And most people we spoke with, 64%, were primarily using opioids, and 29% were using stimulants primarily. So in terms of access barriers to the hospital's SCS, patients identified that they did not want staff knowing that they used drugs or that they were accessing the supervised consumption service. And there was a fear that having staff know this would result in changes to their care, whether that be the drugs that they're prescribed in hospital or how they're treated by staff in terms of potentially experiencing stigma or being treated unkindly. As part of the SCS, the hospital does report back to the unit when a patient that is admitted into that unit has been accessing the supervised consumption service. And that policy is in place in part to limit risks related to if somebody has an overdose or an adverse experience on the unit after leaving the SCS. So patients are aware of that policy, and some are not, don't agree with it. There's also a fear or experiences of judgment. So a quote here as example, like, "I'm really afraid that they're going to look down on me again because of my use." Many patients also cited that they had some initial fears, or they chose not to use the SCS because of these fears of potentially being criminalized. So fear of police or security from the hospital, being in or around the supervised consumption service. And this was particularly true for people who are using meth. There was also limited service offerings that were a barrier for patients as well. And that primarily related to the fact that the supervised consumption service does not currently accommodate inhalation or smoking. And so many patients reported that they had to smoke substances in other parts of the hospital or outside. In terms of facilitators, patients felt that the peer support workers that work with the ARCH team had a really important role to play in helping build trust with the service and understanding what it was about and whether it was worthwhile to access. And this was formal peer support workers working with the hospital, as well as through word of mouth from other patients. And many patients felt, especially the ones that use the site, felt that it was advantageous to use it because they would be able to avoid some formal sanctions related to substance use. So a quote here is, "You don't have to squirrel away in a staircase and risk getting caught and getting kicked out of the hospital." So we also asked staff about barriers to facilitators to providing SCS-related care. So in terms of our staff interviews, there were 20. The mean age was 35 years old. 80% of the participants identified as female or as a woman. 40% of the participants were affiliated with either the addiction medicine consultation team or the SCS. 20% were part of the hospital's complex medical detox unit. and the remainder were 40% were unit staff that worked in the hospital but weren't affiliated with a addiction-specific service. The mean years of working at the hospital was 5, and their range was 8 months to 21 years. And the mean range or the mean years of clinical experience was 8. So when we talked to staff about what some of the barriers were to providing SCS-related care, many suggested that their colleagues in particular, as well as themselves to some degree, had felt conflicted about the SCS or harm reduction. So feeling some moral ambiguity around the idea of caring for patients and their health, and then being concerned that they're continuing to use illegal drugs. So a quote here is like, there's still quite a bit of stigma around that whole harm reduction piece, just because they see it as like, I'm enabling our clients to use drugs when they don't see it as a safety thing. And so it's saying that that attitude was still common in the hospital. Another barrier was a lack of clarity regarding post-consumption care. Some staff cited that their colleagues on the units are a little bit nervous about what to do when someone returns to the unit. And so, for example, if someone was at the SCS and then they return to the unit, some staff voiced concerns about how to know if it's safe to provide medications to that patient. And so example here is, I think, some of the things that they were, which is the concern we always get is they've come back and used, can I give them the medication? And then in terms of facilitators, the staff identified that being able to talk about the SCS with patients and offer it improved their relationship with patients, and helps to create dialogue between staff and patients where patients are more open about their substance use. And another facilitator, staff felt that it was helpful to have an SCS in the hospital because it helped them care and ensure the safety of their patients. So it's a tool I get to have in my back pocket to assist me with helping a patient, for sure. I mean, I don't want anyone using drugs. It sucks, but if it's there, and if we have a place that it can be done safely, then I'd much rather them do that than going outside. So the impacts of the supervised consumption services slide kind of presents areas of agreement between the staff and the patients. And so patients and staff reported that they felt the SCS was contributing to a safer hospital environment. One patient said, it literally saved my life. I would have probably been in a bathroom somewhere if I wasn't there when they had an overdose at the hospital. Nurses felt that there was less discarded needles in the vicinity of the hospital. And it's created a safer overall place for us to work. Some felt that it did contribute to improved hospital culture. So people who use drugs or patients described feeling more welcome and more comfortable, especially when they're accessing the SCS. And nurses described how the SCS delivers non-judgmental, fair and safe care to patients who need it. Many indicated that they felt it helped people stay in hospital to complete their medical treatment. And as one nurse said, I know we've seen a few patients that have actually used us and then they've actually stayed in the hospital to finish their antibiotic treatment or whatever. And these are patients that typically would not or have a history of leaving prematurely. And many reported also that there was changes to patient care associated with the SCS use. And I alluded to this earlier, but both patients and staff described instances that they could think of where patients unit care changed, and that was often in the dosing of medications, holding of medications, or potentially the treatment of patients. So one nurse said patients are feeling unsafe accessing SCS, not because of the SCS, but for fear of retaliation from their home unit. And often those types of episodes were dependent on who was working on the unit, and it was remarkable to think how just one negative experience with one staff member in one rotation throughout the whole hospitalization really shaped patients and views of their care. So some implications for this work. Some patients are more likely to access acute care SCS than others, and there are still a group of patients, and we have quantitative data that shows this too, but I didn't present it today. There are a significant proportion of patients that aren't necessarily willing to access the SCS, even though they're reporting current injection drug use. The SCS may help reduce some risks associated with in-hospital substance use and improve acute care experiences. Staff and patients both outline challenges with SCS-related care on the units particularly that need to be addressed. And implementing new harm reduction strategies should include ongoing staff development and strong communication with patients. Site level policy and more clinical guidance could be helpful to support those staff that are apprehensive in referring patients to the SCS or caring for patients that are accessing it. However, I think our findings really show kind of the looming influence of criminalization on whether patients can access appropriate care in hospital. And so even though the SCS provides criminal, protection from criminal liability for patients, many are still reticent to use it just because of how ingrained it is, the risk of criminalization and how fearful they are of being criminalized. As well, I think the criminalization of substance use contributes to negative attitudes among some staff towards people who are using drugs. Our next steps are to develop implementation guidelines, evaluate the SCS and how it's impacted patient health outcomes, as well as their hospital outcomes. So I'll just wrap it up there. I just want to acknowledge that Chanel Tuan, who is a member of our research team and the Inner City Health and Wellness Community Liaison, was supposed to present with me on this topic, but she's on the front line of both the overdose epidemic and the COVID epidemic in Edmonton, was unavailable. And also acknowledge Bryn Kosteniuk and Savannah Weber, who are trainees in my group who collected the qualitative data for this study. Thank you.
Thank you. Thanks so much, Elaine. All right, so it's we've got about just over 20 minutes for questions, and I see that there is already a question in the Q&A. So I just ask everybody, if you do have a question, lots of super presentations, please do include it in the Q&A, and we will I will direct them to the panel. So the first question that we have in the Q&A is for Janet. The participants wondering whether there was any work undertaken with police to promote understanding of the purposes of the Good Samaritan Law. Was there any assessment of law enforcement officers' views when you're doing your work?
Yeah, I'll start with the second question first. So any assessment of law enforcement officers' views, what I would say is the focus of this study was really on the perspectives of people who use drugs and or would have occasion to find themselves at the scene of an overdose before 911 was called. So it was outside of the scope of this work to look at the assessment of what officers, police officers, law enforcement generally would have to say about this. We're now actually, and then going back to the promoting understanding. So you will have seen in my presentation that one of the things we're looking at now is really trying to figure out what the next steps are, and the advocacy that would be outside the scope of the research, but that at the Legal Network, that's what we tend to do with our research finding is advocacy work. So we've started actually with, not with law enforcement, but with ambulance to try to figure out dispatch and how that process works. I think once we work our way through that, which is, all these things are a challenge, you're working with different perspectives. I think we'll maybe be in a good position to then look at how we promote understanding and a common understanding of the law and of how it's being enforced amongst different law enforcement officials.
In quick, just because
yes,
I've had some conversations with the Toronto Police about this law. And what they've shared with us is they feel bound by the fact that dispatch, and Janet mentioned that earlier, they are actually the people in Toronto that respond to all dispatch calls. We didn't realize this prior to our conversations with them. So they're the immediate first responder, and then they divert the call to ambulance or fire, depending on the case. And the Toronto Police Service at least feels that they cannot remove themselves from the equation because they are the first point of contact from a 911 call. And paramedics also feel, in many cases, I think it's a labor issue, that police need to be there for security reasons. And so we're engaging with the Toronto Paramedic Service and the Toronto Police Service to see if there's some room for flexibility with respect to that kind of that protocol.
That's great. Thank you, Sandra. The next question is also for you, Sandra. What are some of the reasons that an incarcerated person's request to be a part of the syringe program could be denied?
We've been trying to find that answer out from CSC as well. It's very vague. There's a security reason. So it's really discretionary I think it's really up to the warden or the security officer who ultimately, that second and third point of gatekeeping, they would decide. But we know, like, if there's a previous security incident, we have not been able to, for confidentiality reasons, get the responses from CSC, like what has been the rationale for the denial of this many participants. But we know the rejection rate is quite high.
Okay, thank you very much. And so again, I'm going to just encourage folks in the audience to please do put your questions in the Q&A. I have another question. Sorry to pick on you, Sandra, but I do have another question that arose during your presentation. I was just wondering, where do you see things going? I mean, nobody's got a crystal ball, but in terms of these programs, I know everything. You know, COVID has really disrupted a lot, and I'm just wondering if you have any sense of what you think in terms of next steps for these PNEP, the PNEP at the federal level.
Yeah, so we know they're really subject to political whim. We've surveyed the Conservative Party of Canada has said that they will definitely cancel the program if they're re-elected. So we know that will happen. We know that I sort of see an analogy with supervised consumption sites. Like once you reach a critical point, maybe it's harder to roll back. I know there's obvious differences in Alberta and other places, but like there's 11 sites right now where they exist. And I think if we scaled up nationally, it'd be much harder to pull back. But I think it also depends. Like if there's an election and then there's a Conservative Party, we know that they've canceled safer tattooing in prisons. There was a safer tattooing program in 2005 and 6. It was very positively evaluated. They were in 6 prisons at the time. And then there was an election, and it was, I'm forgetting, Stockwell Day.
Yeah.
He was public safety at the time, and he said, no, this is coddling prisoners. We're not going to give them free tattoos, and he canceled the program. So I think we're just going to be as vigilant as we can to monitor the rollout, ensure the evaluation is rigorously done, and we're trying to find some funding to do an evaluation outside of CSE. So there's like eyeballs outside of CSE looking at the program. But that's why the case was so devastating, the loss for us, not having it legally enshrined.
Yeah, no, I can imagine. The lawyer in me feels for you, Sandra, when you get that far into a case, to sort of have a judge say, you know, it's premature is really, it's a difficult finding for sure. A question maybe for the whole panel, and this is something that Elaine raised. You know, one of the threads that runs through each of your discussions today certainly is, you know, the harms that are associated, you know, with the criminalization of drugs and the sort of the specter of the criminal law, how that impacts each of the areas in which you're working. And I was wondering, I know you've all touched on it in different ways throughout your presentations, but I'm wondering if each of you could just, you know, spend a couple of minutes to just give us your thoughts on the role of criminal law and the, you know, the importance of decriminalization. Maybe I'll start with, who would like to start? Can I maybe start with Elaine? Elaine?
Sure. Yeah, so I've been working at the hospital now since 2014, and we've done a whole host of different research projects with people who use drugs, looking at different changes in hospital practice with the intent of trying to improve the acute care experience for people who use drugs. Like, we know hospitals are high-risk environments for people who are using drugs, and that they don't get access to the same high quality and equitable care as other patient populations. And I think it's become, I mean, not that it wasn't, like I've you know, been convinced we need decriminalization for a long time, but I think, you know, our data are really showing that no matter how much you try to change the hospital culture, no matter what kind, like we have needle distribution, we have managed alcohol, we have supervised consumption services, we have you know, harm reduction philosophy that is embedded in all the care that's provided by the addiction medicine team. Like there's peer support workers, you know, that work on the units with patients. Like we do a lot of that stuff, and it's all helpful and patients like it. But at the end of the day, like it's so hard to move the culture in the hospital. Like, and I think it's gotten better, but it is just so hard when drugs are illegal, because as soon as illegal, you know, drugs are there and people are in possession of illegal drugs, all of a sudden it's like, well, they're breaking the law, and you know, how do we handle this? And then it's very, 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 very difficult to change, even for well-meaning people that want to change. And so I think really it's just driven home how all encompassing that law is and how we can't just make spaces where people are de facto decriminalized. Like we really do need to change the law, and that people will feel a lot better, I think, when they're not at risk of being arrested or be criminalized. So yeah, I think if we do that too, we'll have it'll be easier to change the hospital too as a whole, because at the end of the day, the hospital has, I think it has like 10,000 staff. Like it's a huge hospital, right? 850 beds. And those staff are part of society and they're, raised in society. And if we're going to have criminal law that says stigmatize this group of people, like the staff are going to reflect that. And until the criminal law changes, I don't see a lot of avenues to fix that issue.
All right. Tali, what do you think? I see that you've got your mute off.
I just, in preparation, I mean, I totally agree with that. And I think that's a really good point about especially changing when you're thinking of a hospital, it's like the average nurse or whatever, their opinion and how that's affected by criminalization and how it seems simplistic, but that's, it's really simple. This is illegal, this is not. And we do treat people who use alcohol and now use cannabis like a bit differently. And I'm thinking of like the way cannabis and legalization was 2 years ago, and healthcare providers see it differently, society sees it differently, and so it's like, it is like an obvious no-brainer to me. And I think that the amount of what's really important to know is that although we say that we're offering a certain level of care in jails and prisons and offering people treatments and everything, and there is this myth out there, and I'm sure it's happened for a couple people, that going to jail will help you get clean or all of that. But that's not, jail and prison are not really places for people to feel better about themselves. And so, and they're not, and are also not places where it's particularly difficult to get drugs. Like my clients have a harder time finding a lighter than finding fentanyl. So it's just a farce that we're doing anything for people by stigmatizing them and giving them a record and destabilizing all of their treatment, like the amount of care coordination that has to go into when anyone goes to jail and comes out is ridiculous. So I'm tired of talking about it. Like we've been talking about this for so long. Like it's really frustrating.
Yeah. Janet?
Yeah, so I'm not a lawyer, as I always say. I feel like I have to preface it because I work with lawyers. For me, when you live in a culture of criminalization, it honestly shows me the limitations of what changing law, like what the laws as they are can do. So in the instance of the Good Samaritan Law, we could have really looked at it and said, okay, well, these things, we need to tinker with these things to make it work. And really what we came up with was, we could do that, but really, is that changing hearts and minds? Is that getting anywhere around the mistrust that people have with respect to law enforcement because they are, as humans who use drugs, criminalized? So for me, it really shows me that limitation of what changing laws can do, and how, if you don't change the overarching culture, like Elaine and both Tali and Elaine were speaking of, then I just am not sure you're going to have instances where people feel safe inserting themselves in these processes, like by calling emergency response and other parallel situations.
Thank you, Janet. Sandra?
I'll be short and sweet. I've been doing some number crunching in the last 2 weeks, looking at the costs spent on enforcing drug laws. And out of the Canadian Drugs and Substances Strategy, which is a 5-year strategy, we know the first 2 years, they spent $140 million on law enforcement, and that's close to half of the money spent versus harm reduction versus treatment. I've been tabulating the number of drug arrests over the last 6 years. There's like 520,000 drug arrests, and close to 70% of them are for personal drug possession. So imagine if those costs were diverted from policing and law enforcement into treatment and harm reduction and care and supports community-based, what the world would look like. So I think echoing what everybody said, but also for the people who are more motivated by numbers and tax dollars, that is also a really compelling argument.
Yeah, that is a really important point. Very interesting number crunching, Sandra. I always love it too when the lawyers are number crunching. So we have another question from one of our participants, a question for Sandra. Considering the racial, ethnic, and gender components of incarcerated folks, would an intersectional lens be crucial to discussing harm reduction among those incarcerated, specific incarcerated populations?
Yes, absolutely. Short answer. I think we tried to have an intersectional lens in our court case. We employed the Section 15 argument that I mentioned, the equality rights provision of the charter, and we had we brought forth those arguments, but we also had interveners from Aboriginal Legal Services. We had interveners from PASAN who talked about the gender dimensions, the fact that HIV and hepatitis C amongst people in prison is much higher amongst women, much higher amongst Indigenous women. I think the last CSC statistics was almost 1 in 2 were infected with hepatitis C. But that is like, it's like a stupefying number. For HIV, it was close to 5%. So you need an intersectional lens, absolutely. And this is something we've been really striving for in all our advocacy.
Okay, thank you, Sandra. Janet, how effective is the Good Samaritan Law at encouraging people to get involved when they happen upon the scene of an overdose? Get involved, maybe administering naloxone, are not themselves involved in drug use, but are worried about being sued for an ineffective intervention.
I think there's 2 things going on here, and Sandra, you can come into this if I'm explaining it incorrectly, but I think sometimes there's a conflation between Good Samaritan laws that are around, if someone administers first aid, and then though these are not those laws, they're unfortunately named the same. So this law is around like some kind of protection, around charges for simple drug possession. When someone calls 911, it engages the Good Samaritan Law. So there's 2 things going on in your question. The other part of your question was around encouraging people to get involved when they happen upon the scene of an overdose. So per our our first finding around humanizing, I do think that on some level, this has humanized, put a face on how frequent overdoses are happening and how important it is to call 911. I would like to think that people, for example, who may not identify as people who use drugs and who therefore may not necessarily have drug-related charges or anything outstanding against them, may be more inclined to call because they maybe would have less mistrust of police that we find is a big issue for people who do identify as people who use drugs. But I do think there's 2 things going on in your question. So Sandra may be able to add more to that around the Good Samaritan piece about being sued for an ineffective intervention.
Yeah, maybe just really quickly, those are provincial laws, the Good Samaritan provincial laws, and they are different in every province, but they kind of say roughly the same thing with the exception of Quebec, which has a slightly different version of it. But yeah, basically you're protected if you jump in and be a Good Samaritan from liability, as long as I think it's done in good faith, which is different from the federal law that Janet was talking about. But we don't know, we haven't done research about whether the provincial laws have actually motivated people to intervene. I don't think we know the answer to that. Maybe there's research out there, but I'm not aware of it.
Right. Thank you, Sandra. Tali, a follow-up question for you around decriminalization. Do you think that it is the decriminalization of cannabis that has made cannabis use more acceptable or less stigmatized? Or do you think it's because cannabis is not considered to be a quote unquote a hard drug?
I mean, a little bit of both. I mean, I think that, it's funny because people talk to me all the time about heroin versus cannabis and hard drugs. And I think we have to remember that, before Prohibition, people drank opium tea, people still in South America drink coca leaf tea. And because of Prohibition, Prohibition really, leads to the selling of really more and more concentrated things because they're easier to transport. So during alcohol prohibition in the US, I mean, people made moonshine. It was really, really strong and really dangerous. And so I do think, cannabis is a relatively safe drug and people have familiarity with it. But, part of what makes, heroin or those other drugs, hard drugs, is what we've done to criminalize them. It's made it. So, yeah, I mean, I'm sure that is part of it. And I think, I don't think that, everyone should be, I certainly don't think that we should have fentanyl stores, everywhere. But I mean, it's also begs a question if we need to have, places to buy alcohol everywhere, and that needs to be marketed by the provincial government as well. Like, it's, how do we decide what is criminalized or not? Is it by the amount of death or the morbidity? It's, alcohol would be bigger than all those, and tobacco. So it's kind of rambly, but yeah, sure. Cannabis is generally safer. But I think it's also about the criminalization of other substances as well too.
Tali, another question, it's not in the chat, but wondering what kind of advocacy do you think is needed to bolster these services? And sort of at what levels, and also I'll ask that of Tali, but certainly anyone else on the panel who's interested in responding would be great.
I mean, I'm laughing not because it's a general question, because it's really hard to answer, because I have a job and I work for some place, and it's not, I don't necessarily. It's hard to criticize what the federal government has done, because they have, supported supervised consumption. I really do think that we need more support across the board so that it is equal, a little bit more equal in different provinces. The fact that it's, flavor of the month, depending on who gets elected, is really unfortunate. There also really needs to be, when we think about COVID task force, there needs to be opioid task force, overdose task force in every province. There has been one in Ontario. They have not met. I know COVID is keeping everyone busy, but if we ignore this, it's just going to get worse.
Yeah. Anyone else? Elaine, Janet, or Sandra?
Yeah, I don't have the same constraints as Tali. So I would say that I think, ultimately the federal government has been very helpful in many ways, but I'm just dumbfounded that we can't have a conversation about decriminalization. Like, we have the Canadian Association of Chiefs of Police endorsing it. Now we have the Canadian Society for Addiction Medicine endorsing it. We have obviously people who use drugs have been calling for it for years. Like Oregon just decriminalized. Like it's time. Like it is time. And so I think that's a big thing. I think that would solve a lot of problems related to calling for overdose, accessing care in hospital, and supervised consumption services, because a lot of the politicization of those services comes from the federal exemption process, which is necessary because possession and minor trafficking is criminal. So yeah, that's kind of what I would add. I think too, also the federal government has a much bigger role to play in terms of investing resources in this response. Like, it's a national public health crisis. It requires a level of spending that we have not seen before on this topic. And I'm glad that Sandra's crunching the numbers on the Canadian Drug and Substance Strategy, because from what I can tell, the investments have been very modest relative to the population impacts in terms of morbidity and mortality. And they're pretty much on par with what we've always had. And so, like, we need that. It has to happen. And I'm glad to see that there are other political parties at the federal level that are endorsing things like safe supply and further investment and exploring decrim, because I think, it's time. Like, we can't live in this. This is not it hasn't been a tenable situation for a very long time, and it's just getting worse.
Right. Thank you, Elaine. Janet, Sandra, any last comments on that question?
I would just say I completely concur with what my co-panelists have said, and I think that the notion that you can have these loopholes based on whomever might come into power would largely go away if decriminalization were made possible. And I think it would go a really long way to changing the culture here and to changing how people think about it, and the stigma that we know kills people just as much as fentanyl does. So.
All right.
Can I say something, just because there's a report coming out later today Because there's been so much buck passing, I find, between federal governments, provincial governments, municipal governments, the legal network just developed a primer that I just saw in an email about 10 minutes ago is done. It's copy edited, it's laid out. It's a primer for municipal, provincial governments or local health authorities or MOHs to make a request to the federal health minister for an exemption to decriminalize their jurisdiction. So if there is a political will in a local place, in like a city, say the city of Vancouver, the province of BC, they can make that request. It's totally within their power to do that. And we are happy to share it as a resource if you're willing to disseminate it to the conference participants. We'd like pockets of local advocacies to start pushing for decrim.